Kalpana, we heard most of it. I think you just have to start after my introduction. You can start from that point.
Okay, sir. So I would like to, it's my privilege to invite Dr. Anil D'cruz, sir. He's the Director of Oncology at Apollo Hospital Group to lay the foundation stone for this teaching program on head and neck surgery for the postgraduate resident doctors as well as the young budding head and neck surgeons in the society. Sir is well recognized as a global teacher, clinician, researcher, and teacher in head and neck. He was the director of Tata Memorial Hospital and the chief of head and neck services with over 33 years of experience in the field of cancer. Currently, he is also president of Union International for Cancer Control, Geneva. I now invite Sir Dr. Anil D'cruz to start his session on thyroid nodule and cancer, differentiating the good and the bad. So welcome, sir.
Thank you, Kalpana, for a very, very generous introduction. If you can permit me to share my screen, then I would be able to put my slides up. Someone needs to give me the permission to share my screen.
Yes.
Okay, it's okay. I got it. So here it is. My slides are seen.
Yes, sir.
Yes, sir.
Okay.
Yes, sir.
I don't know. It's not going into the full screen mode, but let me stop sharing and start sharing again. There it is. Okay, beautiful. So, good evening, everybody. Kalpana, thank you for a very, very generous introduction. It truly is a pleasure to speak to this group today. I firstly congratulate you and your entire team for this initiative from the MGM Medical College to start teaching programs. That's been one of my passions, and I'll be delighted to continue what I was doing at Tata's. I do take classes still, but it will be great to have it in the area where I now work. I've chosen an important topic, and I think it's relevant to all of us. It's on thyroid nodules, distinguishing the good and the bad. And as you said, I'm Director of Oncology at Apollo. I now wear two hats. So as Director Oncology, I not only give direction to the oncology program, I continue to work as an oncologist practicing head and neck surgery. I also now head the Union International for Cancer Control. For the youngsters listening to us, it's the largest NGO, members from 172 countries committed to the cause of cancer control. And one of the days that we celebrate is the World Head and Neck Day. When Professor Jatin Shah made a request, I was on one of the subcommittees of the UICC then. I wasn't the president then, and we approved and endorsed this day to be celebrated. Again, for youngsters who are pursuing a career in head and neck, there are three very important days in our calendar that we must know. One is the World Cancer Day, celebrated every year on, or commemorated every year on February 4th, an initiative of the UICC, make people aware about cancer, and every year there is a different theme. Then there is the World No Tobacco Day, which is a WHO initiative commemorated every May 31st with a different theme. This time the theme was Commit to Quit. And that is one aspect of tobacco control that we need to work on. 42% of our population do consume some form of tobacco sometime in their life point, and it is one of the reasons that we really need to work as doctors. And the third important day that we are commemorating today, which is the World Head and Neck Cancer Day, which is July 27th. And as you all know, and Kalpana gave some statistics in the beginning, head and neck is the commonest cancer in our country. Anywhere between 27 to 30% of all our population who get cancer have a head and neck cancer. And it is primarily because of the way we consume tobacco and the number of people in our country who consume tobacco. If you contrast this to Western world, head and neck is only 4 to 5% of all their cancers. So it is a big problem, and we must understand that this cancer is preventable because there's one single etiological factor, tobacco. For those who are unfortunate to get it, if we screen and catch them early, we have more than 90% cure rates. Unfortunately, we have 2/3 of our cancers locally advanced with dismal 5-year survival rates. So here we have a cancer that is preventable, amenable to early screening because the oral cavity can be looked in. All you need is a good torch and someone qualified to look into the mouth. And even if you treat, you can cure 90% if you get it in stage 1. And that's why youngsters who are pursuing a career in ENT must understand the nuances of treatment of head and neck cancer. But these are tobacco related cancers, and I chose thyroid because we have a wide range of people who are today attending. I see some of our youngsters from as far as Amritsar and someone from Guwahati, that's Kudush, who's logged in as well. It's really great to have all of them. Maybe at the end, when we have our cases, we'll take inputs from some of these seniors who are today part of the attendees. I bring you greetings from my new home, the Apollo Oncology. It's next door to you all at MGM. When I joined with a mandate to change oncology across the entire Apollo group. We've now started specialization. So we have specialists across each field in oncology. Our patients go through a tumor board. It's not like private practice. So we have a radiation oncologist, a medical oncologist, and a surgical oncologist. And most importantly, we give state-of-art care at a very, very affordable price. And that really is our tagline now at the Apollo AHNM, which is Apollo Hospitals, Navi, Mumbai. I'll be delighted to continue my association with the MGM, come across, operate with you all, teach the youngsters who want to come, scrub up with us when we are operating. Most welcome, a very, very warm welcome to you. And this does not only include those in training, it also includes young faculty who are keen in head and neck. Now, why thyroid? Why did I choose thyroid on the World Head and Neck Day? More than half the cases that I do are redo surgeries. 50% of that means someone has treated these patients basically without a lack of understanding of the biology of thyroid nodules and the relationship with cancer. Patients unnecessarily have to go through a lot of problems. You must understand that thyroid nodules and cancers are indolent, and they do not kill in the vast majority. So no panic that thyroid nodule, jaldi surgery karao, cancer, get surgery quickly. You must understand, and quickly I'll just show you all very simply an algorithm on how we treat these patients. And very, very important, the expertise of the sonologist, the cytopathologist, and the surgeon are very important. Otherwise, you will have the redo surgeries like I see, which are 50% of my practice in thyroid. We also chose thyroid because thyroid nodules are very, very common. If you look even at the Western population, 4 to 8% of general population have nodules on palpation. This young girl seen with a fairly large thyroid nodule. In our country, the figures are 10 to 12% who have goiters. So imagine operating on 10% of our country who have goiters. It's really not needed. Our hospitals will be full with nodules. So you have to understand which ones are good and are left alone and which ones are bad. If you do a sonography on your patients, 30 to 50% of patients have nodules on sonography. Again, you can't be operating all these patients. Therefore, it's important to distinguish good and bad nodules. Look at thyroid cancers. The incidence of thyroid cancers is also increasing worldwide. So nodules are common. Thyroid cancers are increasing worldwide. So people get panicky when they Google. But like prostate cancer, thyroid cancer can be seen in up to 50% of patients over the age of 70 at autopsy, and these are laboratory cancers. So if I just pull out the thyroid of many of us, we will have foci of papillary thyroid cancers, but these are truly laboratory cancers. You don't have to treat all of them. So only some of them need to be treated. Good cancers, we are going to do minimal. Bad cancers require aggressive treatment. So again, nodules have to be distinguished between good and bad because 10% of our population have nodules. So also cancer, because a lot of cancers are incidentally detected. You don't have to treat all. The good ones are just minimal treatment or observation. The bad ones, aggressive treatment like a full-blown cancer. Now, I'm going to drive this point home with a little story about Korea. South Korea is a very affluent country. They had a cancer screening program for 400 US dollars. They were able to screen for 5 cancers below the clavicle: breast, bronchus, stomach, colon, and prostate. Someone in the country, in the health ministry, said, take another $25 and let's put an ultrasound probe on the neck of people who opt for screening. Look what happened. And this is a New England Journal publication. There was a surge in thyroid cancers because the ultrasound probe was put on the neck. Look at the incidence from 1993, 96, 99, and in 2000s when they started this program, the incidence of thyroid cancer shot up. It's today 68 per 100,000. The USA is 10 to 11. In India, we are about 4 to 5 per 100,000. But look at the x-axis. The thyroid mortality is flat. 11% of these patients who had surgery for cancer had hypoparathyroidism, 2% vocal cord paralysis. That's why these were incidental laboratory cancers. 1/4 of surgical patients had tumors less than 0.5 centimeters, and the majority were less than a centimeter. This is not only in Korea. Again, a New England Journal publication, that there's an epidemic because of overdiagnosis. 470,000 women, 90,000 men have been overdiagnosed in 12 countries. USA, Italy, and France most severely affected, and there has been an increase in India as well. So a lot of cancers that we treat are overdiagnosed. We know that the incidence is increasing as population ages. The incidence is increasing as we have better diagnostics, but please remember that all of them do not need to be treated. Therefore, whom do you evaluate? You will only evaluate nodules which are more than a centimeter. Nodules which are less than a centimeter are only evaluated if they are high risk features. So if you have a patient who has a sonography done, comes to your clinic with a thyroid nodule less than a centimeter, don't push them to be evaluated unless they are high risk features. And the high risk features are extremes of age, less than 15, more than 45. If there's a prior history of radiation to the head and neck, if there's a family history of thyroid cancer or there any of the thyroid cancer syndromes, such as familial adenosis polyposis coli, Cowden's disease, Carney complex, they'll have certain very characteristic skin lesions. Or on sonography, you have worrisome features. Now, sonography, CT, MRI are being done rampantly today for other causes. Case in point, a patient has a head injury, patient has a cervical spine pain. They go in for an MRI. MRI is okay, mild spondylosis, refer to head and neck or ENT specialist because thyroid nodule being seen. These are called incidentalomas. It's an increasing problems. Usually these nodules are non-palpable. Otherwise the patient would have come to you and less than a centimeter. So like I told you, don't rush to investigate if it's less than a centimeter. When you look across all the modalities, sono, CT and PET, the incidence of picking up an incidentaloma with a sonography is 50%, with the CT or MRI is 16%, with the PET is 2%. This is done for other causes, not sonography of the thyroid. Sonography done for the vessels because there may be carotid artery stenosis. You will pick up nodules. But look at the right-hand column, the incidence of malignancy. The incidence of malignancy is very, very low, less than 5% in sonography detected nodules. But PET incidentalomas, here is a case in point of a patient with a PET incidentaloma. The incidence is very high, it's more than 30%. Now remember, whenever you see a PET incidentaloma, it should be a bright uptake, only localized to the nodule. Diffuse uptakes are usually thyroiditis and do not need to be investigated. So really for an incidentaloma, you'll only get panicky if it's a PET incidentaloma, and these are usually done for other causes, and they will be referred to the ENT specialist or the head and neck specialist for evaluation. So how do you evaluate a nodule that comes to you, whether it is clinical or it's an incidentaloma detected nodule? So I told you only more than a centimeter, and you will only do it less than a centimeter if they are high risk features, age, prior radiotherapy, or one of those syndromes, or sono suggestive of high risk features, and we'll see what those are. So whenever a thyroid nodule comes to your clinic, only 3 simple tests: thyroid function test first, a fine needle aspiration cytology, and an ultrasound of the neck. There is no role for serum thyroglobulin, no role for CT, no role for MR, no role for PET in the evaluation of thyroid nodules. Only 3 simple investigations: TFT, FNAC, and ultrasound. A CT, MR, PET is done in certain limited indications. A CT is done when you have a thyroid cancer that you want to operate and it is invading the laryngotracheal framework. If you suspect that fixed cord, decreased mobility, you will do a CT. MR is only done if you suspect esophageal or carotid or subclavian artery, because those are better seen on MR than a CT. And a PET is usually done when a thyroid cancer de-differentiates. 95% of cancers are differentiated and they take up radioiodine. So only in de-differentiated cancers or in medullary thyroid cancers that you do a PET. So for youngsters listening, please, if you are asked in exams, a PET is only done in de-differentiated when radioiodine uptake is absent and in medullary thyroid cancers. Otherwise, 3 simple investigations: sonography, FNAC, and thyroid function test. So you first do a thyroid function test. If your TSH is low, that means the patient has toxicosis, and the patient will go for a radionucleotide isotope scan. Otherwise, there is no role for an isotope scan for nodules. Only if the patient is toxic, and that is found out by a suppressed TSH. If it is suppressed, you send for a scan. If you get a nodule which is cold, then you do further investigation. If there's uniform uptake, this black is uniform, no cold nodule, patient goes for isotope treatment, treated for thyrotoxicosis, either with radioisotopes or with drugs. Now, again, a tip to remember is that if the TSH is in the normal range, but slightly on the higher side of normal, it is more associated with malignancy. Always a high TSH, that means hypothyroidism, is a medical problem. We never operate a patient with hypothyroidism, and I'll show you when we treat benign what we need to do. So if your TSH is within the normal range, patient goes for further investigations with a thyroid nodule. So we've done the TFT, ruled out toxicosis. Second test, ultrasound. Why? It's safe, it's non-invasive, it's cheap, it's easily available, it's multiplanar, and it's the investigation of choice for thyroid nodules. The only negative is that it is operator dependent. So I told you in my first slide, of the 50% of redo work I do, whenever you have a thyroid nodule, choose a good sonologist, a good cytopathologist, and a good surgeon. These are curable conditions, even if it's cancer. And you do not want problems because these are all operator dependent procedures. When you do a sonography, you can know the characteristics of the nodule versus the rest of the thyroid. Cystic nodules are rarely malignant. Hyperechoic nodules are rarely malignant. Spongiform nodules rarely malignant. So read the report, don't read the bottom line. In these cases, it's less than 2% malignant. You can use the sonography to target the FNAC so that you hit the relevant nodule and you don't have to redo it. You can follow up a nodule if you have not operated and have objective criteria of increase in the size. And the accuracy depends on the various findings that you see on sonography. So when you read a sonography report, your sonologist must report a TIRAD score. If the TIRAD score is 4 and above, the chances of malignancy are higher. So don't just read the report. If your sonologist is not reporting TIRADs, you need to go to him or her, tell them, please, we want TIRADs reporting. It helps us decide which nodules needs to be operated. I'm not going to go into TIRADs. It's a free download, but basically they look at 5 criteria. Malignancy is usually solid. The nodules are hypoechoic. They are microlobulated with irregular margins. They have microcalcification and they are taller than wide. Now, of these signs, solid, hypoechoic, and microcalcification are most important. And if you have 3 to 4 suspicious features, the chances of malignancy are very high and you will operate your patient. And I put up one sonography for you all to see. Look at microcalcification, these little white dots which you can see marked with a red asterisk. So you can see the nodule with this cross here. It's hypoechoic compared to the rest of the thyroid. You have microcalcifications. You can see microlobulations with the green asterisks that I've marked. They are taller than wider, and they are solid. So these have a very, very high incidence of malignancy. There are other features such as increased vascularity or the presence of metastatic nodes. But when you have a small nodule, it's these 5 points that we look at to know whether it's good or bad. If you don't mug up TIRADs, anything TIRADs 4B, 4C, 5 and 6 needs surgery, and you know that it is a bad thyroid. And the third investigation that you do is a fine needle aspiration cytology. It's the investigation of choice. It's cost effective. In my time, we used to operate a lot of thyroids because FNAC was not well developed. But now it has decreased unnecessary surgeries by over 50% because the accuracy is upwards of 95%. False negative rates are 2.4%. False positive rates are 1.2%. And again, your cytopathologist must report with the Bethesda system of reporting. So if your cytopathologist doesn't do Bethesda, just as if your sonologist doesn't do TIRADS, you must ask them to report. And again, this is Bethesda 1 to 6. As you go higher into 5 and 6, the chances of malignancy increase and these patients need surgery. Again, this is a topic in itself. I'm not going to bore you with this whole Bethesda system. It's a free download. So youngsters, remember TIRADS, Bethesda, download. You can go through it. I'll leave my coordinates with you. I'll be delighted to discuss with you all if you all have any questions anytime when treating a patient or also at the end of this current presentations. So now we've done a thyroid function, we have done a sono, we have done an FNAC, and we know whether the nodule is good or bad using a diagnostic triad. The diagnostic triad look at the clinical features, and I told you extremes of age. If the child is young and has a nodule, 50% are malignant. If the person is old and has a nodule, again high chance of malignancy. Gender. Males rarely have thyroid nodules. For every 5 females, 1 male has it because the thyroid undergoes wide hormonal changes right through the reproductive cycle of a female. So they're more common in females. So if a male has a thyroid nodule, the probability of malignancy is high. I told you family history. I told you prior radiotherapy. If you have a nodule that's fixed, there's hoarseness, there's presence of lymph nodes, obviously these are malignant. On sonography, you look at the TIRADS, that's the second part of the diagnostic triad, and you look at the Bethesda system, and if you have 4 and above, you know that these are high-risk nodules and they need to be surgery. Now in our country, we have a large number of people coming with multinodular goiter as opposed to a solitary nodule because many parts of our country are endemic. They don't have iodine in their diet, particularly if they come in the sub-Himalayan belt, various other regions where iodine may be lacking in the water. Which is more dangerous, multinodular or a solitary nodule? I put up a meta-analysis widely quoted by Yuan Brito. It's in 2013, published in a very, very prestigious journal called Thyroid, looking at the incidence of malignancy in multinodular versus a solitary nodule. Now, again, for those of you all not familiar, in a meta-analysis, you have this kind of a graph drawn, which is known as a forest plot. This line, the vertical line, is the line of unity, which is 1. On one side, it shows one dimension of these studies. On the other side, it shows the other dimension. So we are looking at the incidence of cancer which in multinodular. So if it comes on this side, it is less cancer in multinodular goiter. On that side, it's more. And as you can see, across the various studies, the incidence is quite varied. But when you pool all these data together, you can see that the incidence of cancer is less in a multinodular goiter. So if you have a nodule in a multinodular goiter, even if it's a large nodule, the chances that it is malignant is less than if it's a solitary nodule. And these are in countries such as ours, which are iodine deficient. In US, in UK, developed country where diet is good, the incidence is the same. But for us, We need to remember that if a multinodular goiter comes to us with a nodule, the chances of malignancy are less than if it was a solitary nodule. Now, what nodules, when we see, what do we do with them? Thyroid is a surgical disease, and like I showed you in the beginning, 4 to 8% of population have thyroid nodules. 12% in our country have nodules or a goiter. We are not operating on all. So we look at a diagnostic triad and decide who needs to be operated, clinical features, sonography, and fine needle aspiration cytology. If the fine needle aspiration cytology and the thyroid sonography are non-malignant, benign diseases need surgery only if they are large goiters, usually multinodular, for cosmesis and if they are causing pressure. We always operate on large benign mediastinal goiters because they're growing in a closed space, and mediastinal goiters are very difficult to monitor. If they undergo a malignant change, you can't keep doing a CT scan. Sonography does not reveal a mediastinal goiter. If the goiter is toxic, but the patient is pregnancy, or the toxic gland has malignancy, we would operate these patients. Otherwise, we give medical or radioactive iodine treatment. And as I told you before, hypothyroidism is usually a medical problem and is not operated. Now, lot of people for cosmesis say, "Kharab lagta hai, operation karao," because they are out in practice, they want to do the surgery. But remember, the thyroid is a very important gland. It has 10 to 12 functions, the thyroid hormone. So you don't pull out any thyroid, because I said that these are more common in females. These young girls will have to go through pregnancy. They have to childbear. If you, of course, you can give eltroxin as a replacement, thyroxine replacement, but it is not the same as having the thyroid in situ. You may damage the recurrent laryngeal nerve. They may need lifelong parathyroid insufficiency needing calcium. So cosmesis, generally, if the gland is more than 5 centimeters, it is cosmetically disfiguring. But a 5 centimeter gland may not be so obvious in a lady who's short, stocky, bull-necked, while a lean, thin girl, even with a 2 centimeter nodule, may be cosmetically compromised because of this nodule. And in that case, you use what is known as staging of goiters. If you have a grade 3 swelling, which is seen from a distance, then those usually need to be removed, because this young girl will be out at a function, a party. It's seen from a distance. She's talking to people. People, "Arey, gale mein kya ho gaya?" So those kind need to be removed. But if it's a grade 1 or 2, that is only seen when you extend the neck, only seen 0B when it's palpable, or if it is barely seen in the normal position, you can observe those and need not operate the patients. Some people give eltroxin for thyroid nodules. I've again put a meta-analysis. Is eltroxin good or bad? And there are many meta-analysis, but I put Sudano's meta-analysis. It's old but widely quoted, looking at these 8 studies. And again, as you can see, the diamond giving eltroxin decreases the size of the nodules. But we don't give eltroxin because you have to give 8 patients eltroxin for one to benefit. How long to give eltroxin, we don't know. The moment you stop this eltroxin, the nodules will reappear. The side effects of eltroxin are on the cardiovascular system and on bone. Now remember, these are ladies. As they go towards menopause, they get osteoporosis, estrogens are falling. And you must be knowing that women, we always do scans, they're more prone to fracture. Now imagine a 35, 40-year-old lady with a nodule and I'm giving eltroxin. I'm giving 8 for 1-2 benefit. The moment I stop it, it grows. And L-troxin causes a premature osteoporosis because one of the functions is mobilizing calcium from the bone. So a lady who would get osteoporotic after 50, I'm pushing her into premature osteoporosis at 35. And that's not a good thing to do. And today, current standards is that you do not give suppression L-troxin therapy for thyroid nodules. If they are benign, you'll operate them. And I gave you the indications. Large cosmetic problems, mediastinal, toxic who are pregnant, or if they are causing pressure effect, otherwise you monitor your nodules. I'm quickly going to shift gears for the next 5-10 minutes and talk about thyroid cancers. Please remember that thyroid cancers come in many flavors, but the vast majority in this blue circle is well differentiated thyroid cancer, which is of 4 types: papillary, follicular variant of papillary, follicular, and Hertel. These come out of the follicular cells. You can then have what is known as medullary, which is 5 to 10%. These come out from the parafollicular C cells, which arise from the ultimobranchial body and fuse with the thyroid. And these are of 2 types, sporadic and familiar. Someday we can do a teaching on these cancers in detail. And the rest 5% are miscellaneous, poorly differentiated, PDTC, anaplastic, or lymphoma. Now remember, thyroid cancers is a surgical disease. If they are operable, whatever the histology, except the lymphoma, which is treated with chemoradiotherapy, all other thyroids are treated surgically. The aims of treatment is to remove all the disease in the thyroid and clinically significant lymph nodes. Thyroid is a lymphatic rich organ. Papillary and medullary thyroid cancer are associated with 50% lymph node metastasis. So if you remove all the disease, you minimize the risk of disease recurrence and metastatic spread. And when you do this, you must remember that the thyroid is intimately related with the recurrent laryngeal nerve, the external branch of the superior laryngeal nerve, and the parathyroids, and you must avoid damage to these structures. However good a surgeon you are, the incidence of some amount of thyroid complications is up to 25%. Here is the thyroid. You can see the parathyroid intimately related. You can see the recurrent laryngeal nerve. That's the ligament of Berry. You high incidence of damage, even amongst many good surgeons who are in teaching institutions and others, if you are not meticulous in operating the patient. Look at this cartoon that I've drawn. Look at the blood supply to the parathyroid that's coming from the same vessel, and look at these vessels going to the thyroid. They're the size of a hair. So you have to only take these vessels and save the vessel to the parathyroid, which sometimes is difficult. Even if you save it, sometimes it doesn't function post-operatively. So to avoid these complications, you have to again find out which are good cancers and which are bad cancers. Thyroid cancers come in 2 flavors, and I'm only talking about differentiated thyroid cancers, not medullary, not anaplastic, all 85 to 90% of the differentiated. So the 2 flavors are low risk, where the recurrence rate is 2% and mortality less than 1%. And the high risk, where the recurrence rate is 40% and mortality is 45%. So you recognize which is good, which is bad. For good cancers, low risk, you do less and only a hemithyroidectomy is required. For bad cancers, which are high risk, we do a total thyroidectomy and give radioactive iodine. And I told you the reason you do that is because however good a surgeon you are, if you don't do much, you can have complication rates up to 25%. How do you decide which is low Good cancers, high. If the age is less than 45, now this is the only cancer with age in the staging. Patients less than 45 live, 99% of them live as good as God destined them to live. It's a low risk cancer. Nodule size which are less than a centimeter, which are intrathyroid, which are differentiated or minimally invasive follicular, which are unifocal, no nodal metastasis, no distant metastasis. These are all low risk patients. If you have more than 45, more than 4 centimeters, gross extrathyroidal, aggressive variants of papillary or a widely invasive follicular, the cancer is multifocal, it's associated with nodal mets or distant metastasis. These are high risk cancers and these will undergo a total thyroidectomy. Now for cancers between 1 and 4 centimeters, because those are the cancers that we'll normally see which are investigated. If all these factors are negative, intrathyroid, the cancer is intrathyroidal, it is well differentiated, not an aggressive variant. If it is unifocal, there are no nodal, no distant mets, they still come into a low risk group and these patients can still be given only a hemithyroidectomy. So a 2 centimeters intrathyroidal, differentiated, unifocal, no nodal mets, absent of distant mets, can be treated with a hemithyroidectomy and these are good cancers. Now the world is searching and many of your youngsters must have read of other methods of operating. Should we do it trans-cervical? People are doing trans-axillary. Some are doing periareolar. Some are doing the BABA approach, which is bilateral axillary breast approach. Some are doing retroauricular. Some are doing periauricular. Now they've started intraoral. And soon, before I finally hang up my boots, people might even look at doing per-rectal thyroid surgeries in the belief that it will give better cosmetic approach. They use robotic, they use laparoscopy. But look at all published literature. The majority come from South Korea. Of 31 retrospective series till 2013, 71% came from South Korea. And I told you that's because they were finding nodules less than a centimeter. So don't be too gung-ho about pushing your patient for robotic surgery. If you look at evidence, robotic thyroidectomy is less favorable for cost, for time, and for oncological outcomes for the vast majority, because you'll do 2, 3, 4 in a year. You get a lower number of central compartment nodes. Morbidity, quality of life, and short-term recurrence are similar in both groups. So therefore, open thyroidectomy, OT, should continue to be the standard of care. Robotic thyroid in high volume centers for low volume cancers in patients with high expectations of cosmetic outcomes. Case in point, you have a Priyanka Chopra who comes with a nodule and she wants it out through the axilla because her whole life is dependent on a scar in the neck. She can't be out of business for 6 months till the scar totally vanishes. Small nodule you may offer robotic, but the vast majority of our patients world over, open thyroidectomy is still the standard of care. I'm going to wrap up with a few quick slides that even if locally advanced, and 5 to 15% are locally advanced, involving the strap muscles, the larynx, the recurrent laryngeal nerve, the trachea, the esophagus, you can still operate these patients because outcome is very good. Mayo Clinic largest series, you have a large number of patients living 15 years with locally advanced cancer. MD Anderson, nearly 2/3 of patients live more than 10%. And when I reviewed data at Tata's when I was there, very favorable outcome. And here is the Tata's data that we reviewed, that 2/3 of patients live more than 5 years, which is better than majority of head and neck cancer. So locally advanced operable, you must operate your patients. I'm going to end by saying that thyroid nodules are of common occurrence. Don't rush to treat all your patients. Investigate only more than a centimeter and treat only those that are malignant or benign with cosmetic, pressure, toxic, or mediastinal location. We know that thyroid cancer incidence is increasing, yet all nodules don't have to be treated. We do it only for nodules which are more than a centimeter. Thyroid function test, fine needle aspiration cytology, sonography are the mainstay of the investigations. Of incidentalomas, PET incidentalomas is usually a concern. The others can be ignored. Thyroid cancers need to be triaged into good and bad. And importantly, choose your surgeon wisely for best results. There's enough data to show that those that do more than 25 to 30 thyroid surgeries a year have the least complications. And those that do less than 10 have complications to the tune of 25% that I showed you. So again, thyroid is a surgery everybody likes to do. Majority of patients are going to live 99% long-term longevity. Please don't spoil the voice of your patient. Please don't give your patient permanent hypoparathyroidism needing 10 to 14 tablets of calcium. Get a good thyroid surgeon along with you to do it. And it's a simple surgery and a very fun-loving surgery. I'm currently president of the Indian Thyroid Association as well, and I've traveled the length and breadth of this country teaching thyroid surgery. Many youngsters today do very, very good thyroid. I'll be delighted to come wash up with some of you all, teach you all the technique, or those of you all who want to come when I'm doing a thyroid, you all are most welcome. Tomorrow I'm doing one. It's a very major advanced case, but please, if you inform us before, we'll take special permission, which is difficult because of COVID, but we will take permission and we'll be delighted to involve you in surgery, more to teach the art of thyroid surgery. Thank you once again to everybody for this opportunity to be here. Faculty of MGM, for all of you all to log in early on a Friday afternoon to not a Friday, a Tuesday afternoon to listen to me. These are my coordinates. I'd be delighted to help answer any questions now or later as well. So Kalpana, thank you once again for the opportunity to be here today.
Thank you, sir. Thank you for the wonderful presentation. So shall we start with the case presentation, sir?
Yeah, please.
And we'll take the questions in the end.
Yeah. So maybe we can have some of your faculty also participate if the youngsters are presenting, so that it can be a little more well-rounded, the discussions. But I'm there and I'd be happy to answer. From our side, I've got Dr. Satakshi, my clinical associate. She may also want to chip in with some of the questions. Please, we can start.
Yes. Dr. Nirali Shah, you can start presenting.
Nirali, which year and training are you?
Sir, I'm third year ENT resident.
Okay, so your exam going. So we are going to do it a little exam type.
Okay, sir.
Kalpana, maybe you can also chip in with any questions, because what they want at ENT level, if I'm going a little high, you can tell me. But just for knowledge, we'll cover all aspects.
Right. Thank you.
A very good afternoon, one and all. I am Dr. Nirali Shah, third year ENT resident from MGM Kamothe. I'm going to present a case on multinodular goiter. My patient XYZ, a 40-year-old male resident of Karjat, vegetable vendor by occupation, presented to ENT OPD with chief complaints of swelling in the front of the neck for past 3 months. History of presenting illness. Patient was apparently all right 3 months back when he noticed a swelling in the front of the neck, which was insidious in onset, gradually progressive, No aggravating factors. There was no history of pain, no history of difficulty in breathing, difficulty in swallowing, or change in voice. There was no history of cough or history of fever. No history of weight disturbances or loss of appetite. There was no history of heat or cold intolerance, excessive sweating, tremors, palpitations, or anxiety. No history of bowel or sleep disturbances. No history of bone pain. There was no history of fatigue or lethargy, and no other ENT complaints. Past history, there was no history of hypertension, tuberculosis or tuberculosis contact, asthma, any known allergies, no history of medications or surgeries in past, no history of exposure to radiation. Personal history, this patient had normal sleep, bowel bladder habits, normal appetite, patient consumed mixed diet, and he denied addictions. There was no history of thyroid disorders, any malignancies, or any major illnesses in the family. Coming to general physical examination, the patient was conscious, cooperative, and well oriented to time, place, and person. His general condition was fair. He was averagely built and nourished, afebrile. Resting pulse rate was 76 per minute, regular in rate, rhythm, and volume, taken in right radial artery. BP was 120 by 70 in sitting position. Respiratory rate was 16 per minute. There was no pallor, clubbing, edema, icterus, cyanosis, or lymphadenopathy. No signs of hypo or hyperthyroidism, and scalp and cervical spine examination were normal. Systemic examination, CVS, RS, and per abdomen examinations were normal. CNS examination, patient was conscious, oriented, alert, with normal tone and power in all the four limbs. Coming to local examination, neck examination, on inspection, there was a 7 into 7 centimeter single visible midline swelling in the anterior aspect of the neck, more towards the right than the left side of the midline. Skin over the swelling was normal. The swelling had well-defined margins with bosselated surface.
The
Swelling
screen
moved
is
with
the screen is not.
yeah.
Slide has not changed.
Nirali, stop sharing and reshare. It will start.
Nirali? Nirali, you can forget about that. You can talk on the examination if it is not coming.
We share. Unmute. Is the presentation visible?
Yes.
So sorry, there was some network issue. So coming to local examination on inspection, there was a 7 into 7 centimeter single visible midline swelling in the anterior aspect of the neck, more towards the right side than the left side of the midline. Skin over the swelling appeared normal. The swelling had well-defined margins with bossylated surface. Swelling moves with deglutition and the lower border was visualized. Swelling did not move with protrusion of the tongue. There were no visible pulsations, dilated veins, scars, sinuses. On Pizzolo's method, diffuse enlargement of swelling was noticed more in the right side of the midline. On palpation, it was 8 into 7 into 2 centimeter swelling in the anterior neck, extending from thyroid notch superiorly and 2 fingers above the sternal notch inferiorly, up to the anterior border of right sternocleidomastoid on the right side and left centimeter to the 2 centimeter to the left of midline. There was no local rise of temperature. It was firm in consistency, non-tender, non-fluctuant swelling with well-defined margins. The surface was nodular. There was no fixity to overlying skin, and the swelling was mobile over the underlying tissue. The lower border was palpated when swelling moved up with deglutition. No neck nodes were palpable. Trachea was palpable in the midline above the swelling. Cocker's test, no stridor. Pemberton's test, no suffusion, flushing or dilation of face or neck veins on raising arms. Percussion, dull note was heard over the swelling, and on auscultation, no bruit was heard. Examination for toxic signs, no eye signs of thyrotoxicosis were present, and there were no fine tremors. Oral cavity and throat examination were within the normal limit. Ideal examination was within the normal limits, and ear nose examinations were also normal. Provisional diagnosis in this case. This is a case of 40-year-old male with non-toxic multinodular goiter involving right lobe of thyroid and isthmus. We went ahead with the investigations. The routine hematological investigations and liver and kidney function tests were within normal limits. Pre-T3, T4 and TSH were within the normal limits. USG neck showed right lobe was measuring 8.3 into 7 into 2 centimeter. Left lobe was 5 into 3 into 1.5 centimeter. Multiple nodules were seen in right lobe of thyroid, with largest nodule measuring 2 into 1.8 into 1 centimeter. There was increased vascularity in right lobe with a few areas of macrocalcification. Nodules were seen to abut anterior border of right sternocleidomastoid muscle with increased echogenicity. There was involvement of isthmus, but left lobe of thyroid was normal. There were bilateral subcentimetric lymph nodes seen at the level of level 2, 3, and 4. The impression was TIRADS 3. FNSE was suggestive of cellular aspirate with scanty colloid material. Microfollicular pattern was seen with nuclear atypia and nuclear overlapping, and there was no capsular invasion. Impression was Bethesda 4, which was suspicious of follicular neoplasm. Thank you.
Nirali, did you look? Yes.
Yeah, sorry. Go ahead, Kalpana.
Yes, sir. So on clinical examination, did you look for signs of hypothyroidism?
Yes, ma'am.
You mentioned hyper, but you didn't. Okay, what did you look for in hypothyroidism?
Ma'am, in case of hypothyroidism, ma'am, for hyperthyroidism, I looked for any fine tremors in the hand. Then eye signs were seen. If there was any sign of eye signs for hypertoxicosis, then fine tremors in the tongue fasciculations. Then in hand, any tremors was if any tremors were present.
This was hyper. I asked for hyper.
Okay, ma'am. Ma'am, when patient walked towards me, that time I looked any if patient had a generalized fatigue or lethargy, then facial puffiness, um, uh, edema over the face.
What happens to the pulse,
And
Nirali? Pulse is how much?
Bradycardia is generally seen in hypothyroidism, and and tachycardia is generally seen in hyperthyroidism.
What happens to the eyebrows? Let me see if you know this.
Sir, in case of hyperthyroidism, then there can be loss of lateral 1/3 of the eyebrow hair.
Hypo.
Hypo or hyper?
Uh, uh, in hypothyroidism, sir.
Hypo.
Yes, sir.
I'm going to ask you a question. If you answer, I'll give you the gold medal. Whose sign is it called? Whose sign?
Whose
Star.
Okay, you Google and find out. It's after a queen. It's called some queen, someone's sign. Don't Google now in front of me. Google afterwards.
Yes, sir.
Nirali, yeah, there. Arzu has written. Arzu has put it in the chat. Queen and sign. Okay, listen, Nirali, I think you presented very, very well. All the points were very well covered. But remember, sometimes when they tell you to take for the clinic, you present well. The important thing is that when you go to the exam, you will miss some points. So you should rehearse how you want to present. Always remember in thyroid, three things are very important. Details about the swelling. Second is you will tell about hypo and hyper thyroidism. That's very, because you must know the functional status of the gland. You must know about whether there's pressure or cosmetic problems. But the third important thing is the etiology of the swelling. Whether the patient is on any drugs, whether the patient comes from an endemic area, whether the patient has had prior radiotherapy, whether the patient has had family history. So these four, actually three, but four main points is what you need to cover both in your history and in your clinical examination. Will you remember that?
Yes.
Name some drugs that cause goiter.
Sir, goitrogenic drugs include amiodarone, sulfonylurea, then para-amino salicylic acid.
Good. Name some diets that cause
Sir, vegetables from Brassica family, including cabbage.
excellent. Name some areas in our country where you see more endemic goiters.
Sir, Himalayan areas and Assam.
Sub-Himalayan, because because in Himalayas no one lives, so it has to be sub-Himalayan in the foothills of the Himalayas, because the water has less iodine. Do you know normal iodine requirement for a human being? See, all these questions Kalpana will ask if you want gold medal. If you only want to pass, I'm passing you now.
I'll read this.
Someone has written,
Answer the second.
Pushpa Kishore has written 50, so it's around 100 microns. So that's a fairly decent answer, but I'd accept 50 as well. Excellent. You said Pizzilo's method. What did you say? Pizzilo's method?
Yes, sir.
What is this Pizzilo's method?
Sir, in this method, the patient is asked to put the hands over the occiput, and the neck is slightly in the extended position so that the swelling becomes prominent.
Okay. Do you know two other methods of examining called Lahey's or Kreil's method?
Yes, sir. Sir, in Lahey's method, the one lobe of thyroid is pushed to other side. For example, for examination of right lobe of thyroid, from the left side, the lobe is pushed towards right so that right lobe becomes prominent.
Okay. And Kreil's?
And in Kreil's method is used for the examination of smaller swellings. The thumb is placed over the swelling, and it is palpated for smaller nodule.
Excellent. Did you not sleep last night and kept reading a lot for this clinic?
Not really, sir.
Okay, then why don't we talk about Lahey's and Kreil's in today's day and age? Why are these signs described? But today none of our teachers tell us to do it. Can you tell me why? It's simple. It's common sense. You've answered so well.
With better imaging modalities available, there is no need to.
Absolutely. Because of better imaging, we now can see the nodules even on the posterior surface of the thyroid. So it's much better. So we don't need to do Kreil's and Lahey's method. Excellent. What will you do for this patient?
Sir, this patient clinically, this patient had multinodular goiter involving right lobe of thyroid and isthmus. So I would like to offer this patient right hemithyroidectomy, and we will send the sample for histopathological examination. And if the histopathology is suggestive of malignant changes, then within a week we can go for completion thyroidectomy.
But it's better.
Yeah, I think that's absolutely correct. Why do you want to do completion thyroidectomy in this patient?
Sir, we'll go for completion thyroidectomy only if the histopathology is suggestive of malignancy in this patient.
Why can't you do frozen section and do the surgery at the same sitting?
Sir, in this patient, it is Bethesda 4, which is suspicion of follicular, and for follicular neoplasm, frozen section is not very specific because it will not show the capsular invasion properly in frozen section.
Capsular and vascular invasion needs multiple sections, and you may not be able to demonstrate it in the frozen. Even papillary thyroid cancer is classically diagnosed because of nuclear features, and the nuclear features are better seen on fixed slides because they're clearing artifacts. They're not seen in frozen. So frozen section may not be very accurate. Excellent. Supposing this patient had a nodule on the opposite side as well, then what would you do?
Total.
So then we'll go for total thyroidectomy.
Any role of subtotal thyroidectomy? No, don't get confused. Your answer is correct. It is total thyroid. When I was your age, we used to do subtotal thyroid. We used to leave back a sliver of tissue on both sides to protect the recurrent laryngeal nerve and the thyroids. But now with better techniques, better anesthesia, that's an outdated operation, because God forbid you get cancer in the thyroid and you have to go back to operate. Then it will become a problem, and the risk for those structures is much more. So we will always operate and do a total thyroidectomy. Both lobes are involved. Kalpana, I think she's answered very well. If there's any question you or anybody else wants to ask, you can ask. And if others want to put it in the chat box, please put it. Otherwise, we can move to the next case.
Yes. I think we can move to the next case.
Okay, Nirali, I would give you 9 on 10. I don't know how much Kalpana would.
Thank you, sir.
Arpit, you can start your Arpit Mathur.
Good evening, sir. I'm Dr. Arpit, third year resident. I'll be presenting my case, sir.
Yeah, go ahead, Arpit.
Good evening, everyone. So, my case for today is solitary thyroid nodule. So, this patient, age 22 years, female, engineer by profession, and resides at Kamothi, Navi, Mumbai. She came to our video with chief complaints of swelling over anterior part of the neck since 3 months. History of presenting illness goes by. Patient was apparently normal 3 months back when she noticed a swelling over the anterior part of the neck. It was insidious in onset. Swelling started initially with size of a pea, which progressed to present size. There was no history of sudden increase in size of swelling, no history of difficulty in breathing, hoarseness of voice or change in voice, no history of stridor, no history of dysphagia or odynophagia, no history of weight gain or loss, no history of decreased sleep or anxiety, no history of intolerance to heat or cold, no history of bowel abnormalities, no history of excessive sweating, fatigue or generalized weakness, no history of irritability, tremor and palpitations, no history of dyspnea on exertion or chest pain or any bone pain, no history of loss of consciousness or syncope, no history of trauma to neck, no history of menstrual irregularities, and no other ENT complaints were noted. Past history, patient doesn't have any significant history of illness in the past, no similar complaints in the past, no history of diabetes mellitus, tuberculosis, asthma or hypertension, no history of previous surgeries or blood transfusions, no history of any known allergy to any medications. Coming to personal history, patient consumes a mixed diet, appetite is normal, sleep is adequate, bowel and bladder are normal too. Patient has no history of smoking or alcohol consumption, denies all the addictions. Patient's socioeconomic status is average, and menstrual history is also regular. There was no history of thyroid disorders, any malignancy, or any major illness in the family noted. Coming to general physical examination, patient is conscious, coherent, cooperative, and attentive, well oriented to time, place, and person. She is moderately built and nourished. Weight is 56 kilograms, height is 5'6". There was no pallor, icterus, cyanosis, clubbing, and pedal edema. No sign of hyper or hypothyroidism. Vitals are afebrile, resting pulse rate is 68 per minute, BP is 130/80, and respiratory rate is 16 per minute. Coming to systemic examination, her cardiovascular system was normal. CNS, higher mental functions are normal. Tone is normal. Power is 5/5 in all limbs. Sensory system examination is also normal. Respiratory as well as gastrointestinal system is remains normal too. There was no signs of hyper or hypothyroidism. Local examination, inspection. It was an ovoid swelling is noted in anterior part of the neck involving right lobe of thyroid, approximately 3 into 3 centimeter. Surface of the thyroid of the swelling appears to be smooth. Extension is from midline to right anterior border of sternocleidomastoid. Superiorly 1 finger below thyroid notch and inferiorly 3 finger above sternal notch. Swelling moves with deglutition but not with protrusion of the tongue. There was no visible engorged veins, no visible pulsations, no scars or sinuses over the swellings, and Pislo's method, there was uniform enlargement of the gland. Palpation, no local rise of temperature and non-tender. Inspectory findings are already confirmed. A single round swelling of size 3 into 3 into 2 centimeter involved in the right lobe. Swelling also moves freely in all the directions. Lahey's method, margins over the swellings are smooth and regular. Price methods, no nodularity is seen. Pemberton's test, no venous obstruction, no flushing noted. And Koch's test, no stridor has been seen. There's no fluctuation, no pulsation, no fixity to the skin, and no cervical lymphadenopathy is seen. Percussion, a resonant note is heard over the manubrium sterni. and auscultation, no audible bruit over the swelling. Diagnosis, this case is of 22-year-old female with right solitary thyroid nodule. Investigations are, all routine baseline investigations are done and are normal. Thyroid profile is normal too. Ultrasonography, right lobe is 4 into 3 into 2 centimeter. Isthmus is normal. Left lobe is also normal. There were no calcifications seen, no increase in vascularity. Surrounding structures are also normal. Impression is TIRADS 2. FNAC, cellular aspirate with prominent population of microfollicles, more of colloid with no atypical cellular feature seen, no capsular invasion. Impression Bethesda 3, ATP of undetermined significance of follicular lesion of undetermined lesions. Thank you. Thank you.
Very, very nice presentation. But 2-3 points in your history, you said no history of this, no history of this, no history of this, no history of this. It's better to group your history into there is no history of suggestive of hypo or hyperparathyroidism, such as 1, 2, 3, 4, 5, rather than no, 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 no. So even if you miss one, your examiner knows you're looking. There is no history of any pressure effects like hoarseness of voice, or because you said no, 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 but in your clinical examination, you said no signs of hypo or hyper. There you should have listed the signs, such as eye signs, such as tremors of the hand, such as, so that is one thing, please mention. Don't just say no, otherwise the examiner will stop you and ask you, why did you do Pemberton's? What is Pemberton's sign?
So Pemberton's sign is when the patient is sitting right in front of us, we ask the patient to lift both the hands above his neck and parallel to the ear. If there is any, if this thyroid is retrosternally retrosternal, there will be engorgement of veins as well as there will be flushing of the face seen.
So did you need to do Pemberton's in your patient?
So the swelling is small, but still to elicit, we need to.
No. So I would say that it's not required, because you very nicely said that you are 3 centimeters above the suprasternal notch. You could feel the lower border. So there's absolutely no retrosternal extension. So sometimes if you try to overshow your knowledge, the examiner will trouble you a bit. What is Cocker's sign?
So when we press both the thyroid lobes with our fingers, there might be compression over the trachea that will cause dyspnea to the patient, as well as stridor in some of the cases.
So basically, when you're pressing the thyroid swelling, the trachea is very tracheomalacic, so it's getting compressed, and that's why this problem is happening. It won't happen in a 3 centimeter nodule. So in my book, it is unnecessary to write this, because you can write in your notes, but don't say it, because in both the cases, if the examiner asks you, why didn't you do Pemberton's, you can say, sir, because I could feel the lower border of the thyroid very well. There is absolutely no retrosternal. And exactly the same for Cocker's. It's a small nodule, freely mobile. There is no pressure on the trachea. Hence, I did not do both these signs. Maybe Kalpana will answer this. Kalpana, do they need to say these signs when there is no indication?
No, sir. They don't have to say it, but they have to mention it in their paper so that the examiner knows they know about these tests.
Okay, so then maybe Arpit, you should write it in your paper, but maybe not get into a controversy by mentioning it.
Right.
Okay, sir.
Great. So now what will you do for this patient?
So as on FNAC, it is a Bethesda 3. So we will follow up the patient with the repeat FNAC as well as ultrasonography. If the findings are confirmed again, we will do a lobectomy.
No, so when will you follow up?
Around 6 months, sir. In every 6.
Are you sure? Kalpana is smiling. She's going to ask you some questions. So I want to tell you that MS, whenever in MBBS, you can only give the answer. In MS, the examiner will always ask you why. So if you open your mouth with anything, have the reason why. In MS, you will not be forgiven if you don't know why. MBBS, you can give us the correct answer and we'll pass you, but not in MS. So you are correct. She's a 22-year-old girl. The risk of malignancy is less. You don't want to go in and operate unnecessarily hemithyroidectomy. So you can observe her and you can repeat it after 6 months to a year. You're absolutely fine. The thing is that you don't repeat it within 1 month. It is 6 months or beyond. What signs will you look at to operate on this patient when she comes 6 months later?
So if there's a primary thyrotoxicosis, a patient
she won't become thyrotoxicosis with a solitary nodule. So you have told the patient that your AUS, that is Bethesda 3, we are going to keep you under follow-up. She comes 6 months later, you do an ultrasound. What signs will you look in the ultrasound report to decide whether you want to operate her?
So increased vascularity, any calcifications, size if I increase from the last investigation.
So earlier when the ATA, that's the American Thyroid Association, gave guidelines in 2009, they looked at increase in size. So you could have increase in size in the transverse diameter, in the circumference, or in the volume. But even if a nodule increases in size, it may not be malignant. There could be hemorrhage into the nodule, which is not malignant. Papillary thyroid cancers grow at the rate of 1 to 2 millimeters per year. So after 6 months, there may not be a change in size. Yes. Now in the 15 recommendations, we look for characteristics which I had told you. That means microcalcification, taller than wide. If any of the characteristics change, then only we repeat the FNAC. If the characteristics are the same, even if there's a 1-2 millimeter fluctuation in size, we don't operate the patient. Will you remember that?
Yes, sir.
Great. What surgery will you do?
So we'll do, sir, lobectomy we'll do, sir, for the nodules locally.
Lobectomy or hemithyroidectomy? What's the difference? Should you remove the isthmus?
Arpit?
Arpit is frozen.
Frozen.
Am I visible?
Yeah.
Yes, yeah.
So we'll do lobectomy, sir, as the isthmus will be preserved in that. In hemithyroidectomy, we won't be able to preserve the isthmus.
So by and large, whenever you do a surgery on the thyroid, it's a loboisthmectomy. The reason you want to remove the isthmus even in benign, a large number of nodules are very close to the isthmus. God forbid it comes as malignancy and you're very close. If you have put a clamp saving the isthmus, you will have a close margin, and then if you are planning hemithyroidectomy, it may not be safe. But more importantly, when you leave back the other lobe, it may increase in size when the patient's thyroid hormone demand is higher. In that case, the isthmus across the trachea gives a very ugly sight. It increases in size. While the lobe, which is lying in the gutter, even if it increases slightly, it won't be visible and will not cause a cosmetic problem. So generally, most people do a loboisthmectomy equivalent to a hemithyroidectomy.
Okay.
Okay. So Pushpa Kishore has written that what about doing a core biopsy in this case rather than observing the patient? Then you know that it is Bethesda 3 or 4. Will a core biopsy help?
So I don't know.
You will get more tissue. Will that be correct or not correct?
No, sir.
Anyway, a core biopsy in thyroid is only done when you have a lymphoma, an anaplastic cancer, a poorly differentiated cancer, when the pathologist wants more tissue to characterize. Generally, a fine needle aspiration cytology is enough to demonstrate the changes in the mnemonic of a malignancy. As I told you, the accuracy is upwards of 95%. The factors that don't allow us to know malignancy are capsular and vascular invasion. By doing a core biopsy, you will not have capsule or vascular invasion demonstrated, and hence a core biopsy is not of relevance in Bethesda 3 and 4. Have you understood?
Yes, sir.
Pushpa Kishore, is that okay, or do you have any doubt? You can speak if you want to speak, or is the reason making your doubt clear? Okay, yeah, yes, sir, it's clear. Okay, so the answer is clear. Great. Any other questions, Kalpana? You want to ask anything?
In the right hemithyroidectomy and left hemithyroidectomy, which is more dangerous during surgery? Or where would you expect more problem? On the right side or the left side?
Excellent question, and you have to answer why.
Yeah, basically, what is the difference in the recurrent laryngeal nerve force on the right
Laryngeal
side?
nerve. Right side.
Why?
Ma'am, because of longer course of recurrent laryngeal nerve on the right side.
Longer is on the left.
Okay, left side.
No, your answer is right. It is more at risk on the right side. But why? Your answer is not very correct. Why? So if you know the anatomy of the recurrent laryngeal nerve, on the right side it comes from under the arch of the aorta and it goes straight away into the TO groove. On the right side, it comes from behind the subclavian and is a little more lateral. So the course till it comes into the TO groove makes it more vulnerable. So thyroids are more susceptible to damage the recurrent laryngeal nerve on the right side because of the course which is longer out of the TO groove. Have you got it? Excellent.
Yes,
There's a question again from Pushpa Kishore that what is a non-recurrent laryngeal nerve? Can you tell us a non-recurrent laryngeal nerve? Arpit?
Yes, sir. So it's
Please
a very
answer.
rare anatomical variation, sir.
Yes. Is it common on the right or the left?
Right side, sir.
Can it be seen on the left?
Yes, anatomical variations can be seen on the left too.
Are you sure? Or you're just flying kite? Okay, it is always seen on the right side. It's never seen on the left side. On the left side, it is not compatible with life. It's only seen on the left. It's only seen on the left side in patients who have situs inversus. So when you see your chest X-ray, if the patient has situs inversus, you may you may expect on the left. Otherwise, it is not compatible with life on the left. So it's only on the right side. Will you remember that?
Yes, sir.
Do you know the types of non-recurrent laryngeal nerves?
No, sir, I'll read about it.
Anyway, there's type 1, type 2A and type 2B. One is close to the superior thyroid arteries, one is close to the inferior thyroid, and one comes below the inferior thyroid and comes up. But that may not be important from that. How do you suspect a non-recurrent when you're operating? So I'm giving you a clue. A non-recurrent laryngeal nerve is associated with dysphagia lusoria. Have you heard of dysphagia lusoria?
Yes, sir.
What is dysphagia lusoria?
So,
Where will the subclavian artery be? Okay, so dysphagia lusoria usually occurs because of an aberrant subclavian artery. The subclavian artery normally comes above the trachea. In dysphagia lusoria, it's pressing on the esophagus. So if your sonologist tells you that the subclavian artery is abnormal, then you would do it. Dinesh, I'll call you back. I'm taking a class. I'll call you. Okay. So dysphagia lusoria is you can have suspicion because of that.
okay, sir.
Okay, my last quick question to you. Nirali got the easy question. Sometimes that's the disadvantage. When you're the second candidate, the examiners have finished the easy questions for the first candidate. Where do you find both the parathyroids?
Both the parathyroid. Behind the posterior to the thyroid?
Yeah, but where posterior to the thyroids? Okay, I'll tell you very simply. You remember a circle of 1 centimeter. So
Okay,
at
sir.
the junction of the upper third and lower 2/3 of the thyroid lobe, you will have a tubercle of Zuckerbrandl called ZT. That
Okay,
is
sir.
on the posterior surface. Within 1 centimeter of that, you will find the superior parathyroid. And the inferior parathyroid is seen in the location 1 centimeter circle in relationship to the lower pole. Have you
Okay, sir.
understood? So it's very
Yes,
simple.
sir.
Tonight, just Google, read it, make your notes, put it in your book so that you don't have to read it before you're reading operative steps for the exam. So Kalpana,
Yes.
I thought both your candidates were great. Both were 9 on 10. Congratulations to you as HOD and to the rest of the teachers for preparing them so well.
Thank you so much.
Great.
Thank you for all the tips.
I thought both of them were very, very good. Maybe we should do some of these virtually. You all guys can come over to the Apollo auditorium. We can do a class there with good social distancing plus khana pina.
Yes, sir.
Great.
We can do this on a regular basis.
Done. Pleasure. Or I can come over to MGM as well. There's no problem. Okay. If there are no other questions, I think we are good then.
There's one question from Pushpa Kishore. How should multinodular goiter can be evaluated for thyroid malignancy?
Arpit or Nirali wants to answer.
So actually your network got disrupted. Can you just repeat the question, ma'am?
How do you evaluate a multinodular goiter for malignancy? Pushpa Kishore has asked.
Really moving.
So on clinical examination, if the multinodular goiter is of benign etiology, then there won't be fixity to the underlying deeper structures, but in case of malignancy, there can be invasion to the deeper structures and mobility will be hampered,
But
restricted.
no, Nirali, that is a very rare occurrence, a multinodular goiter. So the nodule is mobile. I mean, if it is fixed, he won't be asking you this question. The examiner will not ask you. The nodule is mobile. Then how do you? First, you should tell him that the incidence of malignancy is less in a multinodular goiter, and I told you that. Now, a multinodular goiter has multiple nodules. So on sonography, you will look for the sonography suspicious features of malignancy. And I told you the 5 features: solid, hypoechoic, microcalcification,
Microcalcification.
microlobulations taller than wide. So the size of the nodule has no correlation to malignancy. So on sonography, whichever is a suspicious sonographic nodule, your sonologist will put a needle into that nodule and send it for testing. And that is the way you evaluate a multinodular goiter for malignancy. Okay?
Yes, sir.
Okay, great.
Any more questions, Arzu? From the audience, any more questions were there?
There's one diagnostic value of dynamic contrast medium enhanced magnetic resonance imaging (DCE MRI) in detection of thyroid carcinoma compared with FNAC and the frozen section analysis in MNG multinodular goiter.
Shashikant is troubling these two candidates. Is Shashikant a student or is he a faculty?
He's a senior.
Okay, Shashikant, this I will answer this. Oh, you're in Saudi Arabia. Wow. Okay. Shashikant, I want to tell you that today MRI and CT are not used for diagnosis at all. You're a consultant and in Saudi Arabia, so I can understand because y'all guys are full of petrodollars, so y'all are doing all these fancy investigations. But quickly, let me tell you, today there is no role of MRI, whether it's dynamic contrast, whether it's ordinary CT scan to diagnose between a benign and a malignant nodule. I told you fine needle aspiration cytology has an accuracy upwards of 95% in good hands, and we will only do a fine needle aspiration cytology. Some people did recommend doing a PET scan for nodules which were Bethesda 4 because PET nodules are more likely to be malignant. But in large series, even doing a PET scan is not cost effective, and the diagnostic accuracy is only 30% as opposed to fine needle aspiration cytology and sonography, which are upwards of 75-80% in high risk patients. So we will not do MR for diagnosis at all. It will be just sono and FNAC as of today. Dr. Pukan has asked about tennis syndrome, but I think tennis is a little complicated and maybe we can discuss it in a little different forum. It's not for the MS level people, but quickly, tennis stands for thyroglobulin elevated negative iodine scan. It's when the tumor is getting de-differentiated, and in those patients we do a PET scan, evaluate, and then treat the patient. And someday maybe I can do a small talk on for y'all on tennis.
Sir, I think we are short of some time over here.
Yeah. So let's end it. Absolutely
Thank
fine.
you so much, sir. In fact, I really want to thank you for giving your valuable time. I want to thank my team MGM for coming up together with a brilliant idea. And obviously, sir, you being very busy in Delhi, still you're able to manage on that day. And you're always very approachable. I really appreciate about that. And finally, I would like to thank Team Santor for coming up and giving us a beautiful digital platform. We really hope, sir, to come in board of your, and thank you for giving us your time and suggestions for this wonderful seminar today. And we look forward to meet you in person and again and again.
Sure. So, Swapnil, thank you very much. I'm sorry I didn't acknowledge you in my thank yous. You were the first person who approached me. Thank you very much. I look forward to working with all of you all, teaching with all of you all, doing research with all of you all, so that we
Sir,
can.
it is actually honored, sir. We are really honored to have you with us.
We can be safer for our patients and do quality work and all learn together. Thank you very much and look forward to more interactions.
Thank you, sir.
Thank you, sir.
Bye.
Thank you very much. Thank you, sir. Bye, sir.